Okay.
Got several people still trickling in.
Okay.
Okay, Dr. Borowski, the waiting room is clear, and I have
Okay.
3 of the 5 members on that I counted.
Okay. And Dr. Joe may be just running late from work. I know he works some on these Fridays too there, so he may just be getting done here. So we'll just let him in when he comes. We do have a quorum, and I want to call the meeting, the emergency dental TAC meeting, to order. We've kind of already done our roll call. Dr. Phil Schuler, Dr. Carol Braun, and Garth Bobrowski are here. So that gives us a quorum. And just a heads up on our meeting today. It's going to be kind of informational for I think hopefully everyone. I don't mean for this to be a 3 or 4 hour meeting. If we get done in 45 minutes to an hour, we'd be fine too. It may not even take that long. But on old business, first I just wanted to thank Commissioner Lee for being open with us and willing to work with us on these Medicaid issues. One of the best I've seen in years and years. So wanted to thank Commissioner Lee for her work and really all the staff in Frankfurt there. I wanted to thank our TAC members. They've put in some extra hours on a lot of these moving targets here. And I want to thank the MCOs for, working with us on ideas, implementing things. And I want to thank anybody else that's picked up a pen or did some typing or whatever for just helping us put this all together. And I think the primary goal of all this is we've got to do something with Kentucky oral health. We've got to move that needle, pun intended, from being 49th in the nation in oral health care. We got to move this up the ladder. And we're going to have this meeting to kind of get some things started and going. And we'll have another meeting scheduled on February that I think we can do some follow-up things with. And
Winston, come here. Come here.
We will. That's the only old business. I just want to kind of get us going on this.
Hey, Garth.
Yes, sir.
Under old business, I'd like to thank Commissioner Lee for putting out the annual report that was put out. It's the first time I've seen that. A lot of good information, that I was able to share, with a lot of folks. Had some great statistics in there. Some of them, very concerning, about our place in the world where we find ourselves. And hopefully through, our efforts here and elsewhere, we can increase the oral health of Kentucky. We're also in the very bottom of the bucket when it comes to life expectancy. And I think it's no coincidence that those two things are, tied together. So again, I really appreciate the annual report and all the work that went into that. Thank you.
Thank you, Dr. Schuler. That was the very first annual report for Kentucky Medicaid, and we hope to have more of those. And we wanted to get that first one out there. It is a little bit dated. It's 2020, but we wanted to get a little bit of input as we go forward. We hope to get that 2021 out and then a 2022 just as soon as we can. Does have some good information, and I think that's starting the conversations on how we can improve, the health status of those that we're serving. And none of us I think on this call or in Medicaid in general, are here for recognition. We're here to actually improve the health status of those we serve, and appreciate, all the gratitude. And again, we're all here for the same reason. And we appreciate everybody that's on the MAC and the TAC and all the work that's been done to kind of start thinking outside the box a little bit, and actually focusing on what do we need to look at as far as services and policies and that sort of thing. So very, very glad to be serving the Commonwealth during this very important and transformative time.
One of our TAC goals is to offer advice and in looking at areas on, like I've got it listed there, in new business of increasing access to care and continue collaboration to get more dentists to see Medicaid patients. We've got to work on this access to care, and this is going to include some new reports and some new information coming out from Commissioner Lee's office, from the MCOs, and maybe we can bring forth this through the TAC and get some things going from 49th up to 45 and maybe up to 38 and up to 29 or whatever it takes. Let's get this thing moving.
Hey, Garth.
Yes, sir.
I hate to interrupt you, but somebody is texting me. It's a phone number, 606 number, that can't get in the meeting. I don't know if it's John or Joe, but they're unable to get into the meeting.
We were having some website issues, so if you can find out who that is, Kelly and I can forward them the meeting invite so that they can get in. I'm waiting on it to get published. The Zoom link on the website was being a little wonky this afternoon.
Okay, I'll text back and forth. I'll jump in when I figure out who it is.
Okay.
Thank you.
Hey, this is Dr. Rich. Can you hear me?
Yes.
I was able to call in, but I can't join the Zoom meeting either. If there's something you can email to me, I'd really appreciate it.
Yeah, this is Joe Petrie that's unable to get in.
Okay, I'll get it to him and Dr. Rich.
All right, thank you.
Thank you.
Welcome.
Dr. Bobrowski, this
Yes.
is Ronnie Coleman. Are you going to share materials online? Because I can't get on the website either, or the Zoom page. I'm just calling in.
Yeah. No, I'm not going to share any screens or anything today. Some of these informational things are on the Cabinet for Health and Family Services websites already. Under DMS. So some of those are already there that we're going to be referencing today. So I don't have any slides, Ronnie. But one of the main things that we hear from our dentists out in the communities is the fees and reimbursements are just not adequate to continue maintaining our dental offices at the current rates. And I am seeing some movement from the MCOs on bringing some of those fees up. Healthcare is a business, and a lot of our dental offices are privately owned, and we're not like some of the hospitals that we get grants and gifts. So these are locally owned offices, but I know used to be we had just about a dentist or more in I think 119 counties, and that number is no longer there. So we've got to work on getting active members working with us on our Medicaid population. Let me see here. One thing, now I'll let you know, we did have a very productive meeting with the Kentucky Dental Association and Commissioner Lee earlier this morning. So we had a very nice, longer than expected meeting, but we got some really good ideas. And going back on the fees and the codes, I've got a list, a pretty long list of, of things that need to be fixed in the DMS, the sheet that they send out on fees. There's some of these are just typos that really have been carried over from other years of those sheets. I think there's some places where some rewording could help make it just a little clearer to understand. And I know one of the questions was, why are the denture fees for an upper denture higher than the fees for a lower denture? And I don't know, in my office, we've always charged the same price for either one. But I guess across the nation, the history behind it is that for some reason, dentists have filed reports, I guess, with insurance companies on, the fee for an upper denture is a little bit more than the lower denture. So when you do the actuarials on it, it just comes up that they're higher. So, but it takes the same amount of time to make one as it does the other. But that might be something to, look at. We would hope that you would move the lower denture fee up to the upper denture, to make it, because in those making these dentures and crowns, we've got lab fees that, of course, they vary from one lab to the other, but that's another cost that has to be evaluated in manufacturing these dentures and crowns and partial dentures. Now, we discussed this morning. Like I said, I've probably got 2 pages of just notes and clarifications that's needed. But what we decided was maybe if any TAC member wanted to make a comment recommendation, and I know Dr. Schuler's already sent me several of those, we can put our list together, and I would say let's just send that to the commissioner's office ASAP, because I know they're working hard on all this, and I think it's changed twice this week, so we want to get this to them so we can get this done. A couple things I did notice, and if somebody can clarify it for me, I appreciate it, was and it may not be necessary in all cases, but under the codes, there is no code for a CBCT X-ray for when we're doing these surgical implant locations, or there's no code for a surgical guide, and I just need further information from someone to help us, guide us, or if that's something that's needed. To me, if you're going to place implants, you got to evaluate the bone, got to evaluate all the tissues. There was another one there that, and I've already talked with one of the MCOs about this, was under the D0120. I think it's right. It's a periodic exam, but it lists down there it requires a prior authorization. But to my knowledge, it's never been a requirement. So I'm just hoping that's a typo. But those are some of the things that we need to look at, and just try to get our public fee list up to date and in order. There's another thing down there about the making partial dentures. Some of them are made with an acrylic base. Some are made with this one material is called Duraflex, or Valplast is another one. It's a little flexible type material. Some partial dentures have to be made with a metal base. So when you add in the metal, that increases the cost. So those are just things that need to be looked at on our fee schedule. and the corresponding narratives on that. But we'll get this list put together, and I don't think we need to go over each one item by item today, but I'd like to ask all of our TAC members or our MCOs for information on that, and see if we can come up with a good updated list on all that with the proper wording. Is there any comments so far on the codes, other fees?
Well, Garth, I sent a pretty long list of stuff to look at, and really the one, and we can work through all that. And I mean, we don't. This call doesn't need to be taken up with a fee by code by code analysis, because some of them don't make any sense to me at all.
Yeah.
And there's one in particular that 4341 perio scaling and route planning. We get paid a little over $100 for a under 21 patient, and 70 some dollars for an adult. Now that is the hardest procedure that a hygienist is ever going to do, is scaling and route planning, and we get paid more. And I know there's a difference between the pediatric codes and the adult codes. And at one point we thought all the adult codes were going to be raised to pedo codes, and that's obviously not going to happen, and that is what it is. But that particular code, that it is tough to get our hygienists, who many times are compensated on production, to get them on board with doing these procedures at that particular fee level. And why in the world especially with that one, it is so much more difficult to do that procedure on an adult. If the commissioner's office could look at that one in particular, and if we could get that fee raised up, even just to match the pediatric fee, which I still don't think is enough, but at least it's a start, would probably make a heck of a lot of sense. And we'll put our comments together with the rest of these fees. There was a few of them. I mean, shoot, there was one or two fees on there. I had to do some digging to figure out exactly what they were.
Right, yeah.
That resin infiltration type of filling, I didn't even know what that was. And it's actually paid at a higher rate than our regular posterior composites. So I don't know what's going on with that one, but, we'll certainly type all that up and get it to the commissioner's office ASAP. But that 4341 code, that affects a lot of people. That's periodontal disease, treating periodontal disease. And that has such an impact, on a person's overall health. As we've talked about, we're trying to raise the overall health of Kentucky as well as their oral health. So if we could get a little bit of help on that one in particular, that would be great. Appreciate all the help on the oral surgery fees. Those are, I know the reasoning behind that. I don't really care what the reasoning was. The fee, that's nice. And we will have more general dentists doing extractions with those fees as opposed to the old fees. Now, some people just don't do many extractions. It's not going to help one way or the other, but some people do. They're just not going to do them for $30 or $40, and I really don't blame them. So hopefully that'll keep some of the load off of our oral surgery offices and help out quite a bit. But yeah, if you could take a look at that 4341 code, that would be very helpful.
Dr. Schuler, could you tell us in lay terms exactly what the hygienist has to do for the scaling?
Yeah, so basically scaling and root planning is removing all the hard soft tissue off the teeth, so all the plaque and all the calculus. And on some of these periodontal patients, that is excessive. I mean, you would not believe the amount of calculus and tartar that's on some of these people's teeth. And it takes a long time to get it off. So this is not only a hard procedure, it's a procedure that takes some time. You can't just whip these patients in and out. It takes an hour and a half to, do some of these quadrants of scaling. And then they also have to remove the infected lining of the pocket. So not only are they cleaning the teeth, they're cleaning kind of the soft tissue side of things as well. And then going over oral hygiene, and you still got, and then at the end of it, you kind of got to do a regular cleaning. You got to polish them up and floss them and do all that stuff. But it is a very extensive procedure. It's very demanding on the hygienist, and I said it takes a lot of time. And I'll tell you, there's hygienists out there that just don't bother with it and just do a regular cleaning in the presence of disease and send them on out the door. And that's not helping people.
Thank you.
Does that help?
Yes, yes, it does. Thank you.
You're welcome.
That is one of the codes that we see quite a few folks on, and we wish that there would be more folks that would just do that, because and I guess we gotta express to the patient that this is one procedure that if you get this done, you will see improvement in the health of your gums. So it is a very important one. And there was another code there. It's like there was no fee listed for a 4-surface composite. So those are just some things there that we need to look at on our codes and stuff like that. But like we said, we're not going to sit here this afternoon and go through it one by one. Dr. Schuler or any other TAC member got any other comments or questions? Okay, going forward.
Garth, can this is John Gray? Can you hear me?
Yes, I can hear you.
Phil mentioned that this may reduce some of the stress on the oral surgery offices, and while that's true, I think from my perspective, what it has the potential to do is offer patients care closer to home. Whether their general dentist will take the teeth out, or maybe some other oral surgeons will be involved. I don't think the issue should be really whether or not the oral surgeons are seeing all they can see. I think the real issue is the patient in a wheelchair after a stroke having to ride 3 hours in a car to get to someone who will treat them. And I would like to applaud whoever has made this decision. And my hope is that the patients will be able to receive their care closer to home, not necessarily by whomever, but at least have some care and not to be subject to this kind of travel. That's just my only comment.
This is Lisa. And Dr. Gray, thank you for that comment. I think that this has been a collaborative effort. There's been several individuals involved, and we know it's not perfect by any means right now. And so I just appreciate the TAC that it's obvious that y'all have taken a lot of time and put a lot of effort and energy into looking at the new codes, the rates. And I think that we're on track. We've got a great team here to be on track to start making some real positive changes. And the reason that we have a different child fee schedule than an adult fee schedule is that years ago, when we increased those rates for children, our thought process then was, the children are going to be our future. Let's increase those rates so that we can get more dentists into the program and get our children healthier as they get into adult. But we did that, and we didn't see a great increase in the number of dentists that were participating in the Medicaid program. So now we're concentrating on these policies and looking at what does it make sense? Where can we put our dollars, such as the preventive, the periodontal disease, the code that we're talking about that can dramatically improve individuals' gums and prevent that disease from progressing. I think this conversation is so exciting as we go forward, and I appreciate everybody. And when the TAC gets those codes and some of their comments back to us, we will go back through and look at all of those comments and make sure that we are having additional conversations and considering any other recommendations that you all have as it relates to the fee schedule and what we need to look at policy wise going forward.
Very good. Now we'll go down to the next thing is on the regulations. There are, and if you want to make a note of it, there's a 907 KAR 1:026. And there's also one, a 907 KAR 1:626 that pertain a lot to our dental business. Now, this is the 026, and it's a emergency reg and an ordinary reg. And one of the other things that is in there is, and I would like to have everybody on our TAC and other folks who look at this, because there is a public hearing on these on February the 27th at 9 a.m. Or you can write comments regarding any proposed administrative regulation, and that is on February the 28th. So, but one of the things that is in these emergency regs, let me see if I can find that. Well, is one of them has to do with local tenants, and this is one of the things that was added in a few years ago and has really become a beneficial thing for offices, especially when folks have got our hygienists have got to be off on maternity leave or dentist. But at this time, I'd like to let Dr. Phil Schuler kind of talk about that, give us a report on that. So, Dr. Schuler. Well,
I mean, so bringing in locum tenens, we've done this for years with the support of the MCOs. We've got a set of guidelines that we use to make sure that they're not employees of ours, that they are truly, locum tenens. And we run them for 60 days and, to help mostly cover maternity leaves, because everybody that goes out on maternity leave right now takes 90 days. So if you play your cards right, you can get at least 60 days covered with one person and then 30 days covered with another locum when you bring them in. But those were conspicuously lined out of the new regulations. And, I'd just like to ask, is that a real thing? And is there some way we can, if it is, there's some way we can work around it? Because we have the full support of all the MCOs in, the way we've been handling it for the past, I don't know, at least 5, 6, 7 years.
Yeah.
So Commissioner Lee, I don't know if you have any thoughts or comments about that, or.
I may have to defer to one of my provider enrollment, but individuals.
Commissioner Lee,
yeah.
this is Jennifer. I'm
Good,
on.
Jennifer. Good.
Here she comes.
Hi, I do have a couple of comments on this. I have, you're not the only TAC that had requested information about locum tenens. And so I had contacted CMS as well as polled some other states. And right now.
On Zoom. It said host is shutting up.
Somebody might need to mute.
And CMS, and of course, what I confirmed with other states, to only allow this for physicians. It's not allowed for other provider types at this time.
So, I mean, where's that coming?
This is John Gray. As the father of 2 women dentists, I just don't see how this is acceptable in any form, fashion, whether you're a woman physician or a woman dentist. It's and that's where the majority of this takes place is post delivery. I think that's not acceptable in any shape, form, or fashion. And that's my comment.
Well, I would agree, John. I mean, what we're trying to do here is to increase, our whole effort is to increase access to care. And I'll tell you what, if you're an independent single doctor that goes out on maternity leave and you're going to have to close especially if you're a high Medicaid practice, and you're going to have to close your practice for 3 months while you're out on maternity leave, or cut your maternity leave short, and we don't want that. But cutting out this locum tenens, it's going to be a very big deal, very big burden, and it will have a negative impact on the ability of our patients to get care.
And it
Is it a
sounds like,
question? Is it a question of the definition of that? that if the federal funding doesn't allow for it, is there just another definition that we can put in place that would replace that nomenclature?
I don't care what you call it, as long as we've got a system where we can bring in under whatever. I mean, we'll play by any rules that we have, but we've got to be able to bring in another doctor under some set of circumstances that can provide care that is not necessarily a credentialed Medicaid provider, whether that's for a very short term, limited access, or something. But I mean, we're certainly willing to talk about it. But I mean, this is probably the biggest thing that's in those regulations that would have a negative impact on patient care. It's a big thing.
And it sounds like Jennifer has reached out to CMS but this is definitely something we can keep on our radar, look and see what other states are doing. And as long as we can get our federal financial participation from CMS, we'll continue to work on this. So I think it's something that we definitely need to keep on our radar.
So as of right now, since these regulations went in effect right at the very end of November, we're not able to do that anymore right now.
Jennifer, I mean, I think that the answer
That's
to that
correct.
is correct. That is correct.
That's right.
So I will be closing a pediatric practice on the 28th of this month.
And so will every other pregnant dentist.
Yeah, and it also it's not. I mean, I get John's point. Short-term disability. I mean, it's more than just pregnancy. That's certainly probably 90% of it. But I mean, if you injure your finger or hurt your back or something, you just need to be out for. Sometimes you have to be out for a month or so, and you've got to be able to bring somebody in, especially if Medicaid, makes up a good chunk of your practice. You can't just cut that out. You go bankrupt. So we got to figure out a workaround, and we need to do it pretty quick.
Okay, let us take that back again. I know we've had, one conversation with CMS, but let us take that back again and see what we can circle back with. Okay,
I appreciate it. And like I say, we had the full support of the MCOs, in the way that we handled this. Mm-hmm. So there was nobody that felt like anybody was being taken advantage of or that anything was being done wrong. I mean, I get the fact that you got to stay within, your federal guidelines, or we don't want the money to get turned off, but still, there's got to be a way to work around this. So I appreciate
federal guidelines that are supporting maternity leave, paternity leave. I mean, this is a big thing nationwide. And I think they're back in the 50s or 60s of the past century. This just doesn't make any sense.
Well, to have it be okay for physicians, but not dentists. I know I've talked to several MCOs, and what the feeling has always been is, instead of physicians, we just swap the word out provider, because I mean, what's the difference between a medical doctor and a dentist? There's no difference. We're all taking care of patients. So for CMS to have a rule like that, I agree with John. It's just ridiculous. And like I say, I mean, 28th of this month, I got a pediatric practice that's going to be open or closed depending on what we find out.
Okay, let us take that back again and have some more conversations and figure out what we can do and see if, I think there's a few questions, and I'm familiar with locum tenens and the purpose, but just not familiar with all of the regulations surrounding them. So we'll take that back and see if we can't get something out to y'all sooner than the 28th. It sounds like that we need to get that out to y'all, Dr.
Well, and I mean, it needs to be as soon as possible, because, now I got a doctor that's been hired to come in and cover maternity leave. We got hundreds. I mean, this particular practice, 70% Medicaid. It's over on Dixie Highway in Louisville. It's a huge Medicaid practice. Yeah.
Commissioner Lee, would it help you if the TAC took a vote on supporting the leave this alone? Would it help you in any way, or could we vote on it at the next meeting? You may not even need a vote. You might just get a consensus and say that our dental TAC is not in favor of deleting this.
Well, I think it's going to be, I think it's at the federal level. Let us take it back. We're going to do a little bit more research on this. I don't think that the TAC needs to do anything right now. Okay. The issue is that that if we can pay for locum tenens, you know, we want to keep that, but definitely we need to circle back with CMS and have some more conversations or see how other states are doing this. So I have a couple of questions. So let me take this back internally and then circle back with the dental tech.
Okay, great.
Well, and Commissioner Lee, the one thing what we're trying to do is not create a system where we've got non-credentialed providers taking care of Medicaid patients. It's just kind of it's a stopgap kind of thing.
Correct. Got it.
All right, Dr. Schuler, do you have any more on comments or things on that issue there?
I'll just wait until we hear something, hopefully sooner than later. Thank you.
Okay.
And I just want to make sure that I have all of my information too. So the individuals that are serving as locum tenens, are they enrolled in Medicaid as a Medicaid provider, or are they just?
No, they're not. We're billing them under the provider who's out on leave. The current guidelines that we've been working under are we can do that for 60 days. They cannot be an employee of ours, so we can't have an employment agreement. They can't have retirement and benefits and all that kind of stuff. They are strictly basically a hired gun to come in and cover the office until that person comes back.
Okay.
Commissioner Lee, can I add something to that?
Yes.
Because all of these come across my desk. And we do a fair number of these across the state where a doctor's out sick on maternity leave, other issues have come up, bereavement, things of that nature. And to keep from shutting their whole office down, they bring an outside doctor in. And one of the things is, they have to be a Kentucky licensed dentist. They have to have, their MPI number. And we do a background check on them when they ask to become a locum tenens to make sure the safety of the patients is taken care of.
So we'll have some more conversations, and see what we can do about this one particular topic, because it sounds like this could be, is turning into a major issue. So let us take that back for a little bit and see what we can do.
Thank you very much.
Okay.
Thank you, Dr. Schuler, for that report. Let's see. Well, I'm not going to bring that part up. Let's see. This is another thing that we've had conversations about is in terms of moving the oral health needle to a more favorable situation for the Kentuckians. I would want to encourage our TAC to just constantly be looking at new ideas, new policies. For instance, we've had some conversations with, just treating gum disease, treating our diabetics, treating our folks with severe dry mouth. If we could come up even with some protocols through the American Association of Periodontists, these are gum specialists, through their organization, I believe is where the diabetic patients, it's highly recommended, encouraged to have them have a cleaning every 4 months. Every 3 months. But even if we could get language in there to cover diabetics and get that extra cleaning in every year, in the long run, it just helps our patients with diabetes. And I think this is a method that can be tracked through the MCOs or through fee for service, but we've just things like that. And I think I made a comment at a meeting or two before, is on some of these things. Let's come up with ideas, even if we've got to think outside the box for a time or two, and just see what'll work and what won't won't work, but we've got to get to the business of treating disease. And, you know, every person has value. And I guess the way I was raised, everyone has value, especially in the sight of God. You know, so we've got to work on treating our patients in our towns and communities. And I know I guess in the word out there is health equity. And we need to see that people are treated fairly, expeditiously, and just we want to help these folks have a healthier lifestyle. And we're just seeing more and more reports from medical people that however the care of the mouth is relates to the rest of the person's health. And you know, it's just been proven and over on heart disease, that the gum disease is related to heart disease. So there's things like that if dentistry can, you know, change this needle, move it up a few notches or all the way, we're going to be doing some good things for people. Now, you know, we can't expect this to happen in 6 months or a year. I mean, this is going to be a year by year effort, and needs to be continued that way and looked at. Maybe things need to change, or there may be new medicines that will come out in the future that will help us. So these are things I just want to encourage and challenge all of our TAC members and our MCOs in the state to see what we can do to move this needle and help. And at the same time, we've got to have dentists, we've got to have hygienists, we've got to have staff to do this. And as you know, a lot of businesses, including hospitals, including dental offices, are really having some staff issues. And if your office is not having them right now, just get ready. I've been blessed with in my office with having assistants that have worked with us here for over 40 years. I've had hygienists that have worked here for 26, 28 years. Other assistants are going on 25 and 30 years. So I've been very blessed. But ever since COVID has hit, it's like every morning I get up and look at my phone and see who's not going to be there that day. And you're talking about the local tenants. It's, I mean, it gets down to where you've just got to come in early and start canceling patients because you don't have staff to treat them. So, but we want to get everybody as healthy as we can. Yes, Dr. Schuler.
So back to the periodontal disease and what we're trying to do to improve people's health. We have a new code in the system, 4910, which is periodontal maintenance. That relates back to what you were talking about of going back in and cleaning these people up again every 3 months. It takes 90 days for the bacteria to get reorganized and start tearing the gums back up. So if we can go in there every 90 days and get them cleaned up, it's a huge help. So the new code, which I appreciate that being included, is $96.80.
Dr. Schuler, you frozen. We can't hear you.
That's the way the fees are set up on those two particular codes. But like I said before, and I won't beat a dead horse, but that's one that if we could get some movement on that, it could make a big improvement in people's overall health. So
yep.
I'll shut up about that one.
No, thank you for bringing that up. I had seen that earlier, that code had been added, and that's a blessing. That can help people.
So you can use that for diabetics, for example, that need to come in more often than every 6 months. Is that correct?
Correct.
Thank you.
Yeah, and I'm sure the MCOs will have some sort of, as they probably should, some sort of guidelines because you can't have a periodontal maintenance done until you've done the quad scalings. So, I mean, you've got to, you can't put the cart before the horse. You got to get them cleaned up first, and then you've got to go back in every 90 days and clean them up again. And it's super beneficial for diabetic patients, for cardiac patients, for pregnant ladies, for maternity situations, because that helps reduce the some of the dangers of preterm babies and low birth weight babies as well. So, not that we have a problem like that in Kentucky at all, but it helps a lot of things.
All right. Let me get my paper over here. Well, I wanted to kind of make folks aware of some of these regs, some of these codes, and just that I just encourage all of us to continue to work together to see what we can do to maintain our dentists and staff, helping each other, work together on getting the codes where we need to have them to where we can even afford to, do these treatments for our people. Now, basically, that's all I've got for this meeting itself. But we're the TAC, I've got some other ideas on, bringing some things forward. And what I'll maybe can do is just email some ideas to you, and then we can present everything at our next meeting and do a vote on it. Unless anybody else has got a different idea right now.
Hey Garth, can we talk about the MCOs and the fee for service rates?
Yes, and I apologize that I can't believe I overlooked that one. One of the things that we really need MCOs is to have you all pay at least the fee for service rates. Now if we have to get rid of this 10% reduction, I guess we will have to look at by either contractual additions or changes, or by doing new contracts, or just legislatively. But it's kind of like I mentioned earlier in our meeting. It's like I wish we had a magic wand that we could just say ask the MCOs, can you help us fix this? And tomorrow it'll be fixed. But we understand there's a process for all this. The other thing is to look at the medical loss ratios. Now this is such a minor point, but I guess when you run a small business, like I do down here in rural Kentucky, we look at every stamp we send out. We weigh it? We have to, we don't have the luxury of we'll just put 4 stamps on it, it'll go, but I received a notice from one of the MCOs just a little while back, and I got 3 4-page letters, concerning the same thing. And basically all it was the guidelines for opioid notification and use. And it was the exact same thing. I got it 3 times. So that's 3 stamps. It could have been handled with 1. But the other thing is, and I brought up, and Dr. Schuler did too, and about staffing. I got a letter the other day, and it was, I guess it's called me not being in compliance with seeing patients in a proper time period. And I think Dr. Cottle, I think you mentioned one other time, unless you hear from you, don't worry about it. But I did get that letter, and I just want to let you all know that we see anywhere from probably, depending on the day and what we've got going on, from 5 to 8 a day up to 30 Medicaid patients a day. And to my knowledge, I've not known of anybody that we've delayed that was hurting. We try to get them in. If they're swollen, we try to get them in that day, and at least see what's going on, and try to take care of their emergency needs. But anyway, I got the letter, so duly noted. And and like I said, when we've got staff that call in and they're sick or they've got COVID, then they're going to be out for 5 days. Or if they've got a small child at home sick, I'm without an assistant. So we just want to let you all know we're doing the best we can out here. But let's see, what else? Anything else from any TAC member on the fees?
Garth, the only thing I would say is, and again, having a fee for service fee schedule from the state is great, but if the MCOs don't follow it, then it's, we're back to haggling with each individual MCO. If there was a way, whether that's, like you said, through contract or through legislation, to have the MCOs, follow that fee schedule. We kind of need to force that issue if at all possible. I don't know what's the easiest way to do that, but that certainly needs to happen, because having a fee for service at one level and then the MCOs come back in and, it's not anywhere near that. I mean, trust me, these fee for service rates are nothing to, do cartwheels about, but less than that is even worse. So I don't know if anybody has any comments about how that might be achieved, or what we might need to do in the future to be able to make that happen.
So I think that all I would say is that the MCOs have to have network adequacy. I think that the providers particularly dental providers, are in a position to negotiate rates. And so I think that, one of the solutions would maybe be for the providers to go back and look at their contracts when it's time for renegotiations, to discuss with the MCOs what those rates are, and to ensure that they have to have network adequacy. And it looks like maybe Dr. Caudle has unmuted his phone. I'm wondering if he has some comments too about that.
Well, I actually unmuted it by accident, but yeah, I can address that. As we all know, we do monitor and do secret shopper appointment checks and so forth to make sure everyone's complying with our contractual obligations. And we do bring it to a doctor's attention if an appointment can't be made. And quite often I'll reach out to a doctor and we'll have a discussion, and they'll explain things like Dr. Bobrowski just said, where, I've got 2 staff people out, I'm doing all I can do. And we may say, well, under the circumstances, if you don't have an opening and there's no staff to see any more patients, we'll be more understanding on that situation. So other than that, we do encourage every office to fully comply with their contract and get the emergencies in within, I think it's 48 hours, and a regular patient in within 30 days.
It's less like, and I'm hearing this from other offices too. I've got one of our hygienists that has blessed us to come and help us, lives an hour and 15 minutes away. So she drives 1 or 2 days a week. That's about all I can get her, is to come in and help us. She's at an hour and 15-minute drive, and she's 73 years old, but boy, she's a firecracker and she gets it done. But my other main hygienist had to have her young daughter at age 13 got Ewing sarcoma, which is a cancer. And we've had to deal with that issue. And then that same hygienist had to have rotator cuff surgery. And then now she's dealing with back problems. So MCOs is be aware that, you know, it's I know y'all got contractual things you have to do, but just we just, you know, kind of out of the blue got this letter, and I've heard of other dentists getting this letter of non-compliance with their timing of getting patients in, but there's many days, as the other dentists on the call here today can verify, that there's a lot of days we don't get lunch. We just work through lunch, and we do the best we can to see our patients, especially if somebody's hurting. But, you know, some of our hygiene needs are just, they're just there because we don't have staff. Talked with one dentist or dentist hygiene deal up in the Elizabethtown area. They've got over 22 offices in that area that are looking for a hygienist. So, and I know there's a law that was passed by the Board of Dentistry that, you know, allows for coronal polishing, but that still does not allow that person to do the root planing or deep scaling, things like that. So it helps, but it's not as good as just having a regular hygienist in the office. But any other comments?
Just to circle back, would a representative of ESIS, DentaQuest, or one of the MCOs speak about bringing fees to the posted CMS fees?
Hey, this is Dr. Adam Rich with United Healthcare. Can you hear me?
Yes.
Hi, thank you. For starters, I'd like to point out that we've always paid at fee-for-service rate or above, and we intend to continue to do that. Obviously, we've already implemented the new oral surgery rates to match the codes, and it's my understanding that those rates are the same for oral surgeons and for general dentists, regardless of the code. That's the intent. Additionally, I say all that, and the intent is to either continue to do the same with these new codes. We are considering, we're looking really hard at it though, and I appreciate your feedback in this as I do it. Obviously, we don't want to do anything that would, but enhance the provider and the member experience. And so we are looking at some of these codes, and the intent would be to incentivize codes like restorations by raising those rates and making the child rates and the adult rates more similar. Not just, but if we can incentivize those, it may be at the expense of some of the codes that don't have as much impact on overall oral health. So we're just kind of look at that. There's a lot of new additions to this. I'm sorry. I thought I heard somebody interrupt. But so there's a lot of new additions. There's a lot of ways that we're looking at this, trying to be as creative as we can to support the provider and the oral health of the members. So, but I just wanted to reiterate that we've always paid the full fee-for-service rate, and that's pretty much our intent going forward.
One of the
Any
things
questions?
Go ahead.
I was just seeing if anybody had any feedback at this time on anything that I'd said there.
Okay.
This is Nicole with ESIS. I'm sorry, go ahead, Dr. Bobrowski.
Go ahead, Nicole. Go ahead.
I was just going to say thank you for the opportunity. For the fees for 2023, the fees will be released shortly. If you haven't already been in contact with Dr. Cottle or one of our provider relations representatives, you will hear from them very shortly. As you know, we believe in open lines of communication, but because this is a contractual issue, it's not something that we discuss in the public forum, but we do stay in contact with the practices, have, as many opportunities that DMS gives us to talk with them, to share the expertise that we bring into the market. So we will continue to participate in those conversations, and then individual fee schedule information we will be sharing with the practices very shortly.
Okay, thank you very much.
Mhm.
I'll just, and I don't know, you're talking about the contractual things and proprietary information, but I don't mind to share this one with you. This is just on my office here, and we're just a rural town Kentucky office. I'd hate to see what the bill is for Dr. Schuler's Mortenson's group, but just for my supplies last month for, we do on these fillings and extractions. I don't think I'd ever seen a bill this high, was over $16,000. Now you think about the number of fillings or extractions that you've got to do to cover that bill. I mean, like I said, we're down here doing the best we can working, but I think that was whatever the billing cycle was for November and December. But that's just an example of the costs. These costs of supplies is just going out the roof. And I think that's why you're hearing more and more doctors talk about the fees and the rates, and MCOs. I just urge you to really consider moving those fees up to at least the child level, because I think that's part of the reason we're losing providers. The more people that we lose as a provider, those of us that are still sticking in there, we're just getting swamped. And then you're getting swamped with fees that are below cost. So we are anxiously waiting for some help. And I'm just speaking of these, our Medicaid providers in rural Kentucky, small town Kentucky, and and those same fees apply to Lexington and Louisville if you're a Medicaid provider. But we don't want to beat that horse anymore.
Dr. Bobrowski, if I may, this is
Yes.
Jeremy Randall with Anthem. I just wanted to chime in and let you know that Anthem's standard fee schedule is set, at or above the fee-for-service rate, depending on code.
Okay, thank you. Any TAC member got anything else we need to bring up, or you want to comment on? Now's the time. Okay, well, let's,
I'm so sorry. I'm
Go
sorry.
ahead.
I was trying to unmute myself, but I was already unmuted and I got disconnected, and I was trying to say something earlier whenever you're asking for some feedback on the fee schedule. But anyway, so my name's Lauren Locke, speaking from DentaQuest on behalf of Anthem. I just wanted to add that we too are, we reimburse at all of the standard fee rate and or above at some of the codes. And we're also looking at some things going into the future for 2023 to maybe incentivize some of those fees and try to help the providers out as well. So I just wanted to get that in there.
All right. We appreciate, as a provider, we appreciate the help and the cooperation that we can get. Just got to keep working together on this. All right. What I'm going to do is I'm going to, and if the TAC members can really go online there and go to the DMS website and look at that fee schedule. And I've got about 2 pages of notes that I'll kind of type up so they're legible. And I think Dr. Schuler sent another page of notes, and we'll put all this together and get this, Commissioner Lee, we'll get this to you as quick as we can. And then that way we can get ideas. And then, but I really do believe that we need to have our meeting on February the 10th, which is about a month away. That's our regular meeting. I just feel like time is of the essence to, look at these codes. We need to look at those regulations. And I think that deadline, let it go down, it was that May or 8, can't even talk, my mouth's so dry. That regulation, public comment period, I believe was February the 28th. Yeah. For the locum tenens was February 28th. So if we meet on the 10th, that'll give us some more opportunity for the commissioner to get back with us. And also, if we've got written comments, we can get those prepared and get those sent in before the 28th. So I hope that February the 10th was our regular meeting. And I would encourage us, I believe we can just try to continue with that meeting. And hopefully, again, it won't be a, 3 or 4 hour meeting. Hopefully we can keep these to, a couple hours here at the most, but I believe we're running pretty good. We're at about an hour, so I believe we're doing good. All right, with hearing no other comments or questions, we will move to adjourn the meeting.
I'll make a motion to adjourn.
Second.
Right. Got a motion and a second. All in favor, say aye.
Aye.
Opposed? Thank you. Everybody have a great rest of the Friday the 13th. Be careful out there. Watch scary movies tonight.
Thank you.
Have a good one. Thank you, everyone.
Bye-bye.